Osteopathy and the treatment of the shoulder. I recently had a 71-year-old patient come to clinic presenting with left shoulder pain, diagnosed with frozen shoulder by the physiotherapist. Now I want to go through this case study for you because it really draws out a lot about treating the shoulder. It allows us to dig into frozen shoulder, what is frozen shoulder, what isn't frozen shoulder, and we can really see how a key diagnosis based on good palpation and good examination of an area really allows us to make a really fast change for a patient and get where we need to go in terms of our treatment. The case details. 71-year-old male, retired, presenting with his left shoulder pain, inability to move the shoulder at all, onset 3 months ago. He was working on a house and he was doing repeated lifting throughout the day. That day it wasn't too bad, achy in the evening. Next day he woke up, couldn't move his shoulder at all. Left it for a little while, then went to see the physiotherapist after a couple of weeks. Physiotherapist saw him twice, diagnosed him with frozen shoulder based on obviously their examination and the fact that he couldn't move it. But they'd also very wisely sent him for scans, and he had an x-ray and an ultrasound of that shoulder, and it showed no rotator cuff tear, no fracture, no obvious problem in that area. So on the basis of that, he was presented to me with this frozen shoulder. Now, if we dig into that as a possibility, well, he can't move the shoulder. We've got something showing us in terms of scans that there's no rotator cuff tear or anything like that, which would cause him not to be able to move the shoulder. So in some respects, it's an okay diagnosis. However, and this is where the power of osteopathy really comes in, if we do a really good thorough examination, then we can either rule in frozen shoulder or rule out frozen shoulder. Because I've on many occasions seen someone come in with a diagnosis of frozen shoulder and it isn't frozen shoulder. Now you do get frozen shoulders, but they are reasonably rare compared to the many shoulders that you will see that aren't frozen shoulders. So examination, I stood the patient up, I did a standard exam, just seeing how the right shoulder moved, how the left shoulder moved, how the neck moved back and forth. The right was fine, good range of motion, 71-year-old, so it's a little bit limited as he goes up, but that's usually not just the shoulder, unless they've had a rotator cuff tear, but usually that's in the thoracic spine, unable to have that extension. Now on the left side, he literally could move it like maybe a couple of centimeters, and so, okay, as a screen, we've obviously got that left shoulder. In terms of neck, reasonably good range, however, on that movement of the neck to the right-hand side, pain on the left-hand trapezius, and again into the left-hand side, pain on the left-hand trapezius. Did a standing exam of the low back, which would just get them to drop one knee to one side, drop the other side there, just to see how that's moving. I did not get him to bend over and touch his toes. I tend not to do that as a screen with elderly unless they're presenting with that low back stuff. If they can drop their knee on either side, so it drops the knee, allows you to see the movement through the spine, same on the other side, that's okay. Then in terms of the screen, I will move on and sit them down. So that's what I then did. I sat him down because I do not want to be doing a lot of movement through this left-hand side and the shoulder and aggravating it before I've examined in terms of my palpation. Because the more painful this is, the harder it's going to be for me to examine and to ascertain whether he has got frozen shoulder, whether he has got a rotator cuff tear. Because don't forget, that scan, that was, I think, 2 months. He went to see the physiotherapist, he got the scan, and then there was a 2-month gap where he didn't have any treatment. He was under the impression frozen shoulder, I just have to wait for it to get better. And he didn't want to go back and have multiple treatments at the physiotherapist because of money, because of cost, because of time. And so he may well have had a tear in the meantime, unlikely because he's not using it, but we can't rule that out. So unless you've actually ordered that scan in the last week, we've got a test for that. So I sat the patient down because I want to be in a stable position where I can control the body well when I do any rotator cuff tear test and other assessments of the shoulder. But the first thing I do is put my hands on his shoulders and get him to breathe in and breathe out and see what kind of movement we have. Now I'm ascertaining whether the rib is moving in the back, whether we're getting good elevation here, but I also come around then from the front and I do it from the front, breathing in and out. Now that allows me to get my hands over the ribs here and over that clavicle area and see what's moving. Now on this left hand side for him, it's not moving at all, it's just completely jammed. So, frozen shoulder, the whole area is seized up, definite possibility. But now we want to come in and palpate because he's telling me it's painful. Now, where is it painful? Is it painful in the shoulder? Well, yeah, shoulder can mean up here in the trapezius. It can be all the way around the back. It can be in the point of the shoulder. It can be in the joint. It can be when you move it. So we need to have a really good examination. When I palpated through the area, it was pretty obvious where the pain was. The pain was in the front here. Now, frozen shoulder, that's not that usual. Rotator cuff, that's not that usual. So immediately I'm thinking, well, what's going on here? And then I get under that arm and I support it. I'm not getting him to do an active movement. I want him to do a passive movement to have it as relaxed as possible so I can start to move it. And when I do that, when I actually start with passive movement, I can get a lot further range to about here with him. Now it's still, from there, it's like, no, he can't do it. But, okay, hang on. Well, what's the difference here? If I can get it here with passive and he can hardly move it with active, is that problem from frozen shoulder? Is that problem from pain? And so that's when we want to dig into this and get a really good diagnosis. Diagnosis is key and it relies on your palpation. And that palpation skills are aided by your active resistive testing and of course your orthopaedic test. So the first thing we want to ascertain here is where actually is the pain. So when I bring him up here, I'm saying to him, where's the pain? He's pointing here. I'm thinking, surely not. Surely this cannot be as simple as this. So, but we don't jump to conclusion. So I have him in this position. I said, pain is in there? I said, yeah, okay. Push down against my arm. Ah, yeah. Push up against my arm. Ah, yeah, okay. A lot of pain. Where's the pain? Is it in here in the joint? No, the pain is right here. That is not rotator cuff, certainly not frozen shoulder. I'm thinking, surely he hasn't just got a pec strain or possibly a pec tear because it's been going on 3 months. So at this stage, I already have a working diagnosis. Now my working diagnosis is some kind of issue with the pec muscle. Now that might not be correct, but that's absolutely fine. And that's why we move on to work out whether that diagnosis is correct or we have to throw it out. And you have to be careful with this. He may be attached to that frozen shoulder diagnosis. Some patients are, some people aren't. But if you just dive in and go, oh, look, I just think this is a simple pec strain, you don't have frozen shoulder at all, you would think that would make the patient happy. Now, that may not. Why? Because they might think, I've just had 3 months when I thought I had frozen shoulder and blah, 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 and all of this stuff. There's emotion that's built up about that. And now you're telling me it's not? You know, yeah, patients, you know, they have human emotions. And so we have to be careful about this. And so what the great thing is, you don't, when you communicate, so as I go along, I'm saying, okay, well, I'm looking at this shoulder, now I'm looking at this shoulder, and why I'm doing that is because I'm ascertaining what's good for this one is normal and seeing what's happening in terms of a variable with this one. We're going to dig in and we're going to look at the muscles in the joint. So I'm talking them through all this. Is that painful in there? Okay, well, that's your pec muscles. So that's not actually frozen shoulder, but we definitely got an issue in there, and that definitely could be stopping the shoulder from moving and freezing up the movement. Now, the link there is key, how we use the word. So I'm saying this is not frozen shoulder. I'm not saying you do not have frozen shoulder, because he might have, or he might be attached to it. This is not frozen shoulder, but this can cause the shoulder to freeze up. So we're not denying his symptoms. And it's an important point, and it's one that I've learned really the hard way, and I don't want you to have to learn it the same way as me. I have lost patients because I've said to them, you don't have fibromyalgia. Now what I was trying to do is make things really positive for them, because fibromyalgia is not something that's particularly easy to fix. But if you've got pain in 13 points of the body and therefore been diagnosed with fibromyalgia but you don't have it, then of course, you know, we're giving the patient hope. You don't have fibromyalgia. And so we must be respectful of the patients, of where they are, of where they think they are in terms of their diagnosis of what they think they have got. So back to our examination. We've got this theory of this pec muscle problem. How are we going to prove or disprove that? Well, if it's a muscle that we think is a problem, the most obvious place to go is active resistive testing. And there's various different active resistive testing that I imagine you know very well. And so we can go and test the different muscles, the pec, the bicep, all the different things. However, there's an issue here, because this person can't move their shoulder very well. And if you just do with me now, if you just slide, say, just your one hand in between your arms, you're that far apart, and then push inwards, does the pec activate? Yeah. Push outwards, does the pec activate? Yeah. Push forward, does the pec activate? Push back, does the pec activate? Yeah, in all of those different cases. You even do that with rotation as well. Now, the key thing here is, yes, it may activate more in different places, more in different positions than others, with different movements. And of course, if we isolate it out and move it in different ways up here, then we can isolate for that active resistive testing. But with this patient, we can't. Whatever movement we do, the pec muscle, even more than when you and me did it, because it's so contracted and the shoulder is rolled round because of this pec contraction, that every single movement that we do causes pain and causes a problem. So we can't kind of isolate out those different specific movements, the different active resistive. However, that doesn't matter so much, because in all of those cases, what we can do is palpate, and we can ask him, where's the pain? And in every single one of those movements I did, the pain was here, nowhere else. Now we add that to our palpation, and we've got that left shoulder rotating all the way around here. Well, that's one of the reasons the pec would do that. We've had 3 months. We've had 3 months of this, and so there's going to be decompensation and all sorts of kind of things going around all through the whole body. But, and this is the key thing, we now have a working diagnosis that has a little bit more evidence behind it, because everything is isolated to this pec muscle. We haven't done any rotator cuff tear test, and really we'd be negligent if we didn't. But how good can we do a rotator cuff in this position? We can't at this point. And so what we do, we switch into treatment. Now you might say, well, you haven't examined the rest of the body and all the rest of it. We have enough information to know that we're safe, and we have enough information to know that we can get in and work on this area. And if we work on this area and free it up and get some more movement, what's that going to do? One, it's going to really impress the patient to start with, and they're going to be like, wow, this is great, and they're going to be more on board, rather than, and I don't mean they're going to think we're wonderful, what I mean is they will be less inclined to think they've got frozen shoulder, and psychologically, physiologically, you'll get those changes. When you get hope, there's like, wow, healing mechanism starts to come up, you know, all of that kind of good juice and potency. So that's one thing we can do. But the other thing, if we get more movement through here, it's going to allow us to do more treatment, but it's going to allow us to do a fuller examination. Maybe now we can get our rotator cuff tear test in. Maybe we can do more isolated active resisted and seeing what's going on. And so that's what I did. I got in and I worked on that pec muscle. Now it wasn't rocket science. It was inhibition, working into that area. Now I did some shock release and things like that, which you may or may not know in terms of technique. Gentle technique in there to try and get the nervous system to shift. But the main key thing here was taking it into ease whilst I do inhibition. So I'm not like mullering the thing, attacking it and making it worse, because in nervous system wise, it's been there for 3 months. If I punish it into there, it's gonna defend from it, it's gonna contract more. So what we do, we inhibit in there as we take in that shoulder, trying to just roll it a little bit more into that internal rotation to allow it to shorten it a little bit more, to allow it to go where it wants to go. We don't want to stretch it, that's going to threaten it. And when I did that, where I'm able just to kind of move it a little bit into this internal rotation, shorten position, and gentle inhibition, then it started to release from me a little bit. Just a little bit, a bit of give. That's all I need. A little bit of give tells me, right spot, body's responding, and we're getting somewhere. And that little bit of give then allows me to just take it the other way a touch with a tiny little bit of stretch, just a little bit of stretch, see how it responds. Oh, it's okay with that. Then we drop back into that other way, work it a little bit. What am I trying to do? I get in camera here, I'm trying to free it up enough so I can tuck. I can come behind there, and I can come out there, rather than it being stuck in that side there. So that's what I'm trying to do. And so I spent 5 minutes, 5 to 7 minutes, working the shoulder until we were starting to get better movement. And now we could come up to here and he wasn't getting pain any further. Yeah? He's really stood. Where's the pain? The patient still says exactly in this spot. But now we've got this better range of motion. And what I can do now, we can do it in this position, or preferably we can lengthen it out. We can start to do rotator cuff tears. In this position, when we do it like that, that's going to stretch, it's going to make it harder. But we can start to do some of that orthopaedic testing. And when I did that, there wasn't any, there was pain, but it was in that pec muscle again. Nothing to indicate rotator cuff. So now we have a lot more evidence to say, A, it's not rotator cuff, B, it's not frozen shoulder, because it's gone from here to up here in terms of movement. So I should specify now, we could get it there before passive. Now he can get it there active on his own. He can get it there. And he, more than that, pulls again. So I'm reasonably pretty confident this is not frozen shoulder, this is not rotator cuff. this is a pec problem. Now it could be a bad tear in the pec, but given that it's starting to free up, that's probably not the case. We've probably got a micro tears in the pec, or just a massive gross contraction in the pec muscle that was a response. The nervous system has gone into complete defense mode. It thinks, oh my God, I haven't done any physical activity for 20 years, and you put me through that, and I bet you're going to put me through that again. I do not trust you. I'm going to lock this shoulder down, lock it down real hard. Doesn't move for 3 months because it doesn't get the right type of treatment. It's going to exaggerate. The nervous system just patterns that on top. How do I know that? Because within 10 minutes of treatment, we've got this much room. If it had been a tear, it wouldn't respond like that. If it had been some major problem in the joint, it wouldn't respond to that. Muscles respond that fast. Not even ligaments respond that quickly. You know, you've got in terms of the coracoid ligaments from the clavicle across the acromion, they're going to take longer. You know, that stretch in the door, it's going to take longer to work those 2 or 3 sessions. This responded amazingly quickly, which made me know I was on the right diagnosis and continued. So we continue with that treatment, re-examination, treatment, re-examination. End of treatment, he could come up to here. Now that's a win. He was delighted with that. I was more than happy with that at all. I can rule out frozen shoulder and the other things. We got a pec strain, absolutely 100%. Now, did I give him any exercise at that point? I didn't, and the reason being, the whole thing needs to calm down and settle. He's had some treatment which is going to stress the area as well, even though we were cautious with what we did, worked within the range of the nervous system. But he's had this for 3 months as a strong patterning. So I just said to him, I want you to move where there's no pain. You come up here and there's pain, you back off a touch. So I just want him moving in this range of motion. Now I did give him this guy, I said you can just kind of roll this back and roll around this like this, forward, back and forward within the range that doesn't cause you pain. I want to reinforce 100% to his brain the shoulder will move with no pain. If the shoulder will move with no pain, it means there isn't a serious problem. The nervous system can down-regulate and the whole thing can start to integrate. This is the term functional treatment in osteopathy. What is functional treatment? Well, it can mean you do different things with your hands, but what it means is you want to integrate the part that's not working with the whole. We're talking about integration of this part back into the whole system. If you get that result from a treatment, even if you only get a little range of motion improvement, what will happen over the next 3, 4, 5 days, it will improve greatly. And that's what happened with him. I said, I'll see you in 5 days' time. We saw him in 5 days' time. He had maintained all of that motion. He could still be up here without any pain. Went any further, problems. And then we moved into the second treatment, which was looking at all of the other stuff that had been stuck for 3 months. Yes, we worked that shoulder a little bit more. I repeated the rotator cuff. Now he could come up a bit further. And yes, absolutely no problem there. So that's all great. Continue with our working diagnosis with the pec problem. But now I need to work on the clavicle. Now I need to work on the scapula. Now I need to work on the thoracic spine and the neck. All of the things that you can imagine are not going to be happy if I do this to you and I say stay like that for 3 months. You know it's going to affect all of those things all the way down into his low back. Now to wrap this up, before we finish, I want to mention what exercise we gave him at the end of that second treatment, because that is important. Now we've got that established that the shoulder's starting to move in, we can give him something more to do. And so I gave him these little exercises where he would, in the doorway, he couldn't get up really high, but I wanted him in the doorway reasonably low, he could get to there, and I asked him just to push gently into that doorway so we can get this gentle stretch through the pec and through that whole shoulder complex. But I had to demonstrate to him, then get him to do it, and then correct it, and tell him what he should not be doing, because sure as eggs is eggs, he's going to push more and he's going to strain it more. So I had to be really, really firm with him. This is how far I want you to do it. Can you feel it here? He goes, no, I can't. I said, exactly, that's what I want. That's what I want you not to be able to feel it in here. Because the natural inclination is to go until you feel the stretch. No. I said, I want you to go to the point where there's no stretch. If you go there and you feel stretch, you come off. Why? Because I'm not so much targeting that pec. Yes, we're getting that pec. I want to get those ligaments in there that have changed. The ligaments from the clavicle through the acromion. They need stretching out to allow that shoulder to come out of that internally rotated position, to open up, which is going to allow the work on the scapula and the ribs to take, and the whole of that shoulder complex to make that next leap to the bigger change. So that's what I saw him in the second treatment. I saw him in the third treatment, and about 5% left to go. 95% change, almost fixed. Osteopathy has everything in it that you need to fix problems like this. What has it got in it? It's got excellent principles in terms of the way we go about diagnosing things, the way we listen to the patient, the way we take all of that information in, put it to one side, don't ignore it, put it to one side, and then do our examination, and then we take that information back out and we mesh the two. What the patient is saying to what we're finding. And then that sifts through in our brain and we come up with a working diagnosis. It's not something we're attached to, it's something we're working with. And then we do some treatment and some more examination to see if that's proved. If it isn't, we change our mind, and if it is, it continues through. So this is the power of osteopathy. It's not just the techniques, it's the principles of the examination and the history and the way we put all that together and look at the body as an entirety. So I hope this has been great use to you. If you like it, hit the like button so then I know to do more case studies like this, because there's so much content we can do. We can do case studies, we can do footage, we can dig into principles, we can talk about how we deal with patients, we can talk about growing a clinic, all sorts of things. I could talk about tax if you wanted to, not much fun, but it's something we still need to do. So there's so much that we can talk about. So I need your guidance, so subscribe, hit the like button, then I know what kind of material is going to make the biggest difference for you.